Hello, this is high yield cardiology tailored to the emergency medicine shelf exam. Unstable angina is defined as sudden chest pain at rest. Stable angina is defined as chest pain occurring often during activity, which resolves at rest. Prinzmetal's angina is coronary artery vasospasm. It occurs at rest. It can improve or worsen with exercise. Patients may or may not have underlying coronary artery disease. The EKG will show ST elevation that cannot be distinguished from an acute MI. Laboratory workup will show normal troponin level. That's the key here. Treatment is nitrates to treat the vasospasm. Non-STEMI and a STEMI. For the non-STEMI EKG findings, you'll see ST depressions or T-wave inversions. A STEMI, you'll have ST elevation due to a full thickness or a full wall thickness injury, which will later progress to a Q wave. A STEMI is defined as greater than 2 millimeter elevation in contiguous precordial leads or greater than 1 millimeter in contiguous limb leads. Remember, the precordial leads are V1 through V6, and limb leads refer to 1, AVL, 2, 3, and AVF. An inferior MI, I want you to think of 2, 3, and AVF. That's the RCA dominant. For lateral, I want you to think of 1, AVL, V5, and V6. That's the left circumflex. And then anterior, that's going to involve V3 and V4. That's often the LAD. Posterior MRIs, you're going to have the ST elevation in V7 through V9. Those are the leads that are going to go on the back close to the scapula. And then they're going to have ST depressions on V2 and V3 and tall R waves. The most common EKG presentation for digoxin toxicity is accelerated junctional rhythm. In the setting of left bundle branch block, you want to think about Scarbosso's criteria to diagnose MI in the setting of a left bundle branch block. So you get 5 points if the ST elevation that is concordant with QRS in at least one lead, 3 points for ST depression greater than 1 millimeter in V1 through V3, and 2 points for ST elevation greater than 5 millimeters in discordant with QRS. Greater than 3 points, you have a 90% specificity for a STEMI. Biomarkers, that's troponin. You're going to see it rise within 6 hours. It's going to stay elevated for 1 to 2 weeks. And troponins are cleared through the kidneys, so renal failure, sepsis, etc. All of those things can also raise troponin levels. CKMB is the best test for reinfarction. There's 5 types of MI, 1 due to ischemia, 2 type 2 MIs are secondary to ischemia caused by increased oxygen demand or decreased oxygen supply. So you want to think about hypertension, coronary artery spasm, anemia. Type 3 is cardiac arrest or other sudden unexpected cardiac death. Type 4 MIs are associated with angioplasty or stents, and then type 5 is associated with CABG. I know you're familiar with the Mona Bash, but the big thing to know here is when you do thrombolysis versus PCI, if the PCI will be delayed greater than 90 minutes, you want to choose thrombolysis. The most common cause of death within the first hour of onset of an MI is VFib. All right, so status post-MI complications can be seen in this table. Ventricular arrhythmias occur within the first hour. Ventricular free wall rupture occurs within the first week. It's the most common complication, by the way. And then papillary muscle rupture occurs within 1 to 14 days after an MI, and Dressler syndrome occurs 2 to 8 weeks after an MI. Remember that Dressler syndrome is treated with NSAIDs. Heart failure exacerbations or decompensations present with dyspnea on exertion. Systolic heart failure, put simply, is just pump failure. So it's the inability to pump adequately. And diastolic failure refers to just the inability to relax. The table here shows the causes of high output heart failure when cardiac output is higher than normal, whereas low output heart failure is when the cardiac output cannot meet the body's demands. The treatment overall is diuresis. Infective endocarditis presents with a new heart murmur, petechiae, splinter hemorrhages, Osler nodes, Janeway lesions, and Roth spots. I talk more about those in the dermatology video. If you'd like to view that, I'll put it down below as well. Risk factors are underlying rheumatic or congenital heart disease, prosthetic valve, IV drug use, mitral valve prolapse, and pacemaker. Mitral valve is the most commonly affected valve. The aortic and then tricuspid valve is the third most common. There's one exception, and that's when the tricuspid valve is the most commonly affected, and you'll see that in IV drug users. Native valve endocarditis is the most common culprit is Staph aureus and then Strep viridans. Endocarditis in an IV drug user, you want to think of Staph aureus. Prosthetic valves, the early endocarditis within 2 months of valve replacement is Staph epidermidis and then Staph aureus. 2 months after valve replacement, think strep viridans. The management includes drawing 2 blood cultures from 2 different access sites, and you want to start vancomycin. The following procedures require antibiotic prophylaxis: dental cleaning, rigid bronchoscopy, cystoscopy. This does not include endoscopy or colonoscopy. In the prophylaxis cases, antibiotic is usually amoxicillin. A big valvular disorder you do not want to miss is rheumatic heart disease, and it can occur 2 to 4 weeks after group A strep pharyngitis. You want to look for Jones criteria, which includes arthritis, carditis, chorea, subcutaneous nodules, and erythema marginatum. It is the most commonly acquired valve disease in the world, and it can present as late as 20 years later. That's why we always treat initial strep pharyngitis with antibiotics. And then aortic stenosis, it's got the classic presentation of exertional dyspnea, chest pain, and syncope. The murmur is crescendo to decrescendo murmur that radiates to the carotids. And if a patient has elevated blood pressure with aortic stenosis, antihypertensive of choice is hydralazine. And if the patient needs pressors due to low blood pressure with concomitant aortic stenosis, you want to choose phenylephrine to improve coronary perfusion. Mitral stenosis will present with a loud S1 and an opening snap. The EKG may show AFib or left atrial enlargement. Rheumatic heart disease is the most common cause of mitral stenosis. And then mitral valve prolapse will present with a mid-systolic click. It's often in young women who may present with paroxysmal supraventricular tachycardia or premature atrial contractions. And then lastly, hypertrophic cardiomyopathy has an autosomal dominant inheritance pattern. Frequently asymptomatic until sudden cardiac death. The treatment is beta blockers, and the major cause of death in these patients is VTAC or VFib. Pericarditis classically presents with that sharp pleuritic chest pain, which is relieved when the patient leans forward. It's often due to viral in etiology. Physical exam, you may hear a friction rub. The EKG will show PR depression with diffuse ST elevation throughout all the leads. The treatment is NSAIDs and colchicine. Pericardial tamponade presents with Beck's triad of jugular venous ascension, hypotension, and muffled heart sounds. The EKG will show electrical alternans. The treatment is IV fluids and then pericardiocentesis. The number one cause is trauma, and the second most common cause is neoplasm. Hypertensive urgency, which is when you have an asymptomatic patient with elevated blood pressure, typically less than 180/110, whereas hypertensive emergency is when the patient has elevated blood pressure with evidence of end organ damage, which includes things like angina, heart failure, MI, dissection, encephalopathy, renal failure, and then flare-shaped hemorrhages, soft exudates on fundoscopic examination. You want to reduce the blood pressure over several days in hypertensive urgency. The treatment for hypertensive emergency, on the other hand, is you want to reduce the MAP by 25% in the first 24 hours. Nitrates dilate both veins and arteries, leading to significant drop in blood pressure. So you want to be aware that nitrates can cause reflexive tachycardia. Labetalol is an alpha and beta blocker and is therefore contraindicated in heart failure, bradycardia, and bronchospasm. Aortic dissection often presents with sudden onset chest pain and upper back pain. The chest x-ray will often show widened mediastinum. The next best step is to lower the heart rate with a goal of less than 60. Once this is done, blood pressure should be lowered to target systolic ranging from 100 to 120. You can use nitrates, but only after you've used beta blockers on board first, because you want to prevent that reflexive tachycardia that nitrates cause. Once target pulse rate and the targeted blood pressure have been achieved, confirm the diagnosis with CT imaging. And then transesophageal echocardiogram is the best test for hemodynamically unstable patients. There may be no risk factors at all when these patients present with aortic dissection. However, the number one underlying risk factor is a history of hypertension. And then briefly, Stanford A is the ascending aorta, which requires surgery, where Stanford B is the descending aorta. You want to medically manage oftentimes with beta blockers. And then a difference of 20 millimeters of mercury or greater between each arm is considered a poor prognostic factor associated with a high mortality rate. Abdominal aortic aneurysm is often due to weakness in the tunica media, leading to slow and continuous dilation of the aorta. Most are asymptomatic until they expand so much that they rupture, resulting in sudden severe low back pain and abdominal pain. Some patients may present with syncope. And the number one risk factor of abdominal aortic aneurysm is smoking. And the CT can diagnose in stable patients, ultrasound for hemodynamically unstable. If it's greater than 5 centimeters or expanding greater than a rate of 0.5 centimeters a year, you need to undergo elective repair in the OR. If they're hemodynamically unstable, then take them to the OR. Acute limb ischemia can be as dramatic as a patient losing their limb or even their life. So the most common cause is chronic atherosclerosis that eventually leads to thrombosis of an occluded artery, but you can also see it in embolic as well. Signs and symptoms include pain, pallor, paresthesias, paralysis, poikilothermia, and pulselessness, which is a later finding. The treatment is immediate anticoagulation and vascular surgery. Consult for consideration of thrombectomy. And then there is also a possibility in these patients with reperfusion injury once they've been treated, and that will present as muscle pain, hyperkalemia, renal failure, and elevated CK levels. Lyric syndrome occurs in males 30 to 40 years of age, and it's characterized as a peripheral arterial disease affecting the abdominal aorta as it transitions in the common iliac arteries. The triad is impotence, pelvic and thigh claudication, and absence of femoral pulses. Superficial thrombophlebitis is often benign in nature and self-limited. You can see it in patients who just got an IV, and then a few days later, it feels like a tender, palpable cord. Treatment is NSAIDs and warm compresses. These can lead to DVT, so you want to get an ultrasound to cover your basis. And then the American College of Chest Physicians recommends anticoagulation for patients that present with lower extremity superficial thrombophlebitis, who are also at increased risk for thromboembolism, and that includes those that are have affected segments greater than 5 centimeters with risk factors for DVT. And speaking of DVTs, the Wells criteria is used to determine the likelihood of a DVT. A score of 1 to 2, you have a 17% pretest probability. A score of 3 or higher, the DVT is likely. These are the most common arrhythmias you'll see. So first degree heart block, the PR interval is greater than 200 milliseconds. Only treat if these patients are symptomatic. Second degree Mobitz type 1, the PR interval progressively prolongs until one beat is dropped. Think longer, longer, longer drop. That's how you do the Winky block. Second degree Mobitz type 2, the P to P and the P to R intervals are regular until one beat is dropped. The R to R interval is irregular. Third degree or complete heart block is when the P to P and the R to R intervals are regular and the PR intervals are irregular. Wolff-Parkinson-White is a combination of congenital accessory pathway and episodes of tachyarrhythmia. Accessory pathways or bypass tracts are abnormal paths that conduct impulses. So AVRNT stands for atrioventricular reentry tachycardia, meaning that the bypass tract is located between the atria and the ventricles. Wolff-Parkinson-White is a type of AVRT. You want to look for that classic delta wave in Wolff-Parkinson-White, and procanamide is the treatment. Digoxin toxicity can present as 3 different arrhythmias. PVCs are the first sign of toxicity, and then paroxysmal atrial tachycardia, often with a 2-to-1 AV block. Bidirectional VTAC is the third form, and the treatment is digibind. Indications include cardiac arrest, life-threatening dysrhythmia, potassium levels greater than 5, ingestion greater than 10 milligrams or greater than 5 milligrams for kids. And then supraventricular tachycardia, also known as SVT, is a regular, narrow, complex tachycardia with a rate between 150 to 200. The treatment is vagal maneuvers first and then try adenosine. MAT, or multifocal atrial tachycardia, is an irregular narrow complex rate greater than 100, and it's commonly associated with COPD, heart failure, pneumonia. It's defined as 3 or more non-sinus loci, also known as 3 different P-wave morphologies. The treatment is IV magnesium, and treatment includes treating just the underlying cause of what put them in that arrhythmia. Brugada syndrome is an autosomal dominant inheritance, and the EKG shows persistent ST elevation that leads V1 through V3. It's commonly seen in young males with heart disease. It can lead to syncope and death. Treatment is you want to place an ICD. And then TCAs, you want to take, you want to think about TCAs also when you're looking at EKGs. When they're taken at higher doses, they can lead to seizures, but they can also lead to ventricular dysarrhythmias. The EKG will show interventricular conduction delay, prolonged QRS, and or QRS greater than 100 is predictive of seizures, and greater than 160 leads to VTAC. The treatment is sodium bicarb until the QRS normalizes. And then hypothermia, the classic finding you'll see is J point elevation and those Osborne waves on the EKG. And then in terms of torsades, sometimes there's no known trigger. Sometimes electrolyte abnormalities can trigger it. The treatment is magnesium, and then replete any other abnormal electrolytes. And then you want to treat the underlying cause. Unstable, you're going to defibrillate.